Hello everyone, I am Dr. S. Karthikeyan, Professor of Oral Medicine and Radiology, currently employed as Principal and Head of the Department, Adi Parashakti Dental College and Hospital. In this video, I will be discussing about the popular topic, oral potentially malignant disorders. The oral cancer accounts for approximately 3% of all malignancies diagnosed annually in 270,000 patients worldwide. Oral cancer is the 12th most common cancer in women and the 6th in the men. Cancer is the second most common cause of death after heart disease in developed countries. And it is the third leading cause for mortality following heart and diarrheal diseases in developing countries. Almost 90 to 95% of all cancers is oral squamous cell carcinoma, and 95% of the oral cancer occurs in individual older than 70. Whereas if it is below 40 years, in the year 1973, it is 3%, it was 3%, and in 1993, it has increased to 6%. So while discussing oral potentially malignant disorders, we should also know some common terminologies that is used with this context. First is the white lesion. The white lesion is a non-specific term used to describe any abnormal area of the oral mucosa that on clinical examination appears whiter than the surrounding tissue and is usually slightly raised, roughened, or otherwise of different texture from the adjacent normal tissue. So the term white lesion does not denote any specific entity. It is an umbrella term just used clinically just to denote the white appearance. Similarly, the term red lesion is also a non-specific term used to describe an abnormal reddened area of the oral mucosa, which on clinical examination appears smooth and atrophy looking or granular with velvety texture. The next term which I am going to describe is premalignant lesion. Premalignant lesion is defined as a morphologically altered tissue in which cancer is more likely to occur than its apparently normal counterpart. Examples are Leukoplakia, Erythroplakia, and oral submucous fibrosis. So this term denotes there is a clinical change in the oral mucosa or a histopathological change in the morphology of the tissue. Then only it is called as premalignant lesion. Whereas the term premalignant condition is described as a generalized state associated with significantly increased risk for cancer, and there may not be a structural change clinically or histopathologically. So such examples of such condition are pseudopenic dysphagia, syphilitic glossitis. In general, there was a lot of confusion in the clinical usage of these two terminologies. But there is a general understanding that the premalignant lesion as such will be converted into cancerous lesion. So in premalignant lesion, majority of the changes are in the epithelial area. And whereas the premalignant condition, there may not be a clinical change, and majority of the changes can be in the connective tissue, and the entire oral cavity is vulnerable. Any one site of the entire oral cavity is vulnerable for carcinomatous changes. So to avoid such a confusion, WHO in 2005 has come with a term called as potentially malignant disorder. Whether it is a lesion or condition, if there is a defined risk of malignancy at the time of initial diagnosis or at a future date, the lesion can be called as potentially malignant disorder. Regarding the classification of oral potentially malignant disorder, it is classified into high risk, lifestyle related, infection, immunodeficiency, and inherited disorder. So in this video, I am going to discuss about Leukoplakia and Erythroplakia, which comes under high risk group of lesions. And in the lifestyle related The other conditions in this group are oral submucous fibrosis and erosive lichen planus. In the second category, lifestyle-related disorders, we have uh, smokers, tobacco keratosis, which is otherwise called as pouch keratosis. Second is the reverse smoker's palate. Third is actinic cheilitis. And in the third group of lesions under the infections, we have candidal leukoplakia or hyperplastic candidiasis and viral infections caused by HPV and EBV and HPV and HSV and syphilitic infection. And the fourth category is the immunodeficiency. We have solid organ transplantation, graft versus host disease, and chronic cutaneous lupus erythematosus. And the fifth category is the inherited disorders. We have xeroderma pigmentosum, diskeratosis congenita, epidermolysis bullosa, and Bloom's syndrome. So in this video, I'm going to discuss about leukoplakia and erythroplakia. Regarding the etiology of oral potentially malignant disorders, we have extrinsic factors and intrinsic factors. So the first is the tobacco in any form, whether it is smoking tobacco or smokeless tobacco. Second is the alcohol. Third is the viral infection. Fourth is the bacterial infection, that is Treponema pallidum. And fifth is the fungal infection, including candidiasis. And sixth is the electrogalvanic reaction. And seventh is the ultraviolet radiation. And eighth is the chronic inflammation or irritation from sharp teeth or chronic cheek biting habit. Under the intrinsic factors, we have three important conditions. First is the genetic, 5% are hereditary. Second is the immunosuppression, whether it is an organ transplant or HIV or other causes for immunosuppression. Third is the malnutrition, which includes iron and vitamin deficiency. So these are the generally accepted factors said to have an etiological role in oral potentially malignant disorder. So now let us start our discussion about leukoplakia. In the year 1967, WHO has defined leukoplakia as a raised white patch of the oral mucosa measuring 5 mm or more, which cannot be scraped off and which cannot be attributed to any other diagnosable disease. And this definition does not carry any histological connotation. Because of the increased availability of the research data, in the year 1978, WHO has revised the definition as a white patch or plaque that cannot be characterized clinically or pathologically as any other disease, and this definition does not carry any histological connotation. And in the year 1983, it was again revised as a white patch or plaque that cannot be characterized clinically or pathologically as any other disease, and it is not associated with any physical or chemical causative agent except for the use of tobacco. Among the pre-malignant conditions, among the potentially malignant disorders, leukoplakia is the most common keratotic, non-scrapable white lesion associated with the habit of tobacco usage with malignant potential. So the diagnosis of leukoplakia is in general by exclusion. The accepted etiological factor is the tobacco usage, but in the case of leukoplakia of the lip, UV radiation is accepted as a factor. There are many other factors like chronic irritation, electrogalvanic current, iron deficiency, vitamin A deficiency, microorganisms like Treponema, candidiasis, and human papilloma virus has been implicated but not yet established as an etiological factor. Why a leukoplakia appears white? The reasons for the white appearance of leukoplakia is hyperkeratosis, that means increase in the thickness of keratin, acanthosis, increase in the thickness of spinous layer of the epithelium, and production of abnormal keratin, which is having an increased tendency to imbibe fluid from the saliva. So these are the reasons why a leukoplakia lesion appears white. Regarding the clinical feature, majority of the leukoplakia are asymptomatic and unilateral. It commonly occurs in males above 40 years, and the most common sites are buccal mucosa in smokers and buccal sulcus in smokeless tobacco users. The less common areas are palate and retromolar area. And Leukoplakia appears as a white patch which is non-scrapable and it does not disappear on stretching of the oral mucosa. So these are the clinical features. Coming to the clinical types, we broadly categorize Leukoplakia into homogeneous type and non-homogeneous type. If the entire lesion of Leukoplakia is uniform and appears white, it is called as homogeneous. And if there is a mixture of red and white lesion, it is called as non-homogeneous type. Okay. So the homogeneous types are subclassified as smooth, if it is having a smooth surface, corrugated, if the surface shows a beach at ebbing tide appearance, cristae, if it shows a fine pattern of lines, and wrinkled, if it shows a dried, cracked mud appearance. Whereas in the case of non-homogeneous type, there will be a background of erythema based on the size of the white areas. If it is very small, it is granular. If it is larger area, it is nodular. If there are equal red and white areas, it is speckled leukoplakia or erythroleukoplakia. And the fourth type is ulcerative leukoplakia. And there are two special types mentioned in the classification. One is verrucous leukoplakia and second one is proliferative verrucous leukoplakia. Now let me show you the classification, how it has been revised by WHO as years pass on. In the year 1998, WHO has subdivided leukoplakia into thin, smooth leukoplakia. It corresponds to the previous older terminology, pre-leukoplakia. Second is the thick, fissured leukoplakia. The third is the granular or vericiform leukoplakia. And the fourth one is the erythroleukoplakia. This classification was again revised in the year 2002 by WHO as phase 1, which represents thin, smooth leukoplakia. Phase 2, thick, fissured leukoplakia. And phase 3 is the PVL, proliferative verrucous leukoplakia, having higher malignant transformation rate. And the fourth one is the erythroleukoplakia, having poor prognosis. So this is the classification proposed by WHO. Now let us clinically see the different types of leukoplakia. Here you are seeing a patient with a white patch, non-scrapable, on the buccal mucosa towards the angle of the mouth. The surface appears smooth. Here is a white lesion which is seen on the involving the entire buccal mucosa in a smokeless tobacco user, and the surface looks like elevated beach at ebbing tide appearance, corresponding to the description of corrugated type of leukoplakia. Next one is a case where you can see a diffuse area of white lesions, and the white lesion is divided into small compartments, something resembling the cracked mud appearance of a wrinkled type of leukoplakia. Very rarely, leukoplakia also may show fine striations. This type of leukoplakia is called as the cristae type of homogeneous leukoplakia. So I almost show you all the types of homogeneous leukoplakia, including the smooth, corrugated, wrinkled, and cristae. Now let us see the non-homogeneous type of leukoplakia. Here you are seeing diffuse erythematous area involving the buccal mucosa towards the angle of the mouth, and in the middle you see fine small granular spots of white area. So this type typically looks like the granular type of leukoplakia. And if there are larger areas of white spots, it could be nodular type or erythroleukoplakia type. And here I have shown a case where the central area will be ulcerated. Periphery is typically keratotic and non-scrapable lesion. Such type of leukoplakias are called ulcerative leukoplakia, and it is commonly seen in smokers. And the role of candida in this type is said to be having a major role. And in such cases, if we treat these lesions with the anti-candidal therapy for 7 to 10 days, dramatically it changes the appearance into a more of a homogeneous type of leukoplakia. And the next lesion is called as the PVL. PVL strikingly differs from other type of leukoplakia, being it involves multiple sites. It spreads from one site to involve many sites. So and it is more common among females in contrast to the other types of leukoplakia. So, for the sake of completion, I have shown you the various epithelial dysplasias that can be seen in the histopathological examination, including enlarged nuclei and enlarged cells, large and prominent nucleoli, increased or altered nuclear cytoplasmic ratio, hyperchromatic nuclei, pleomorphic nuclei as well as pleomorphic cells, and dyskeratosis, that means individual cell keratinization, increase in abnormal mitosis, loss of polarity, keratin or epithelial pearl, bulbous or tear-shaped retipex, and the connective tissue shows congested vessels and lymphocytic infiltration. So these are the possible dysplastic changes that can be seen in an leukoplakic lesion or a pre-malignant lesion. So this is the classical appearance. Here you see a white lesion involving the gingiva and extending into the buccal mucosa. Okay, and also there was involvement in the floor of the mouth and labial mucosa. So it is extending to multiple sites. A classical description suits this clinical presentation is proliferative verrucous leukoplakia, which is having a high malignant potential. They say that in such lesions, we need to take multiple biopsy from different sites. One side it may show a benign keratosis, and other side it may show a frank invasive squamous cell carcinoma. And there was one more controversial term that is called as the verrucous leukoplakia, where the surface will show cauliflower-like surface projections. And many of the clinicians question the validity of this term. Why? Because 90% of the time when they take biopsy, it proved to be a verrucous carcinoma. So whether we need to use this particular term clinically or not is left to you. And once we take a biopsy, based on the dysplastic changes in the epithelium, if it is involving the basal and suprabasal layer, it is classified as mild epithelial dysplasia. If the dysplastic changes are seen from the stratum, from the basement membrane to mid of the spinous layer, it is moderate dysplasia. And if it is seen, the dysplastic changes are seen from the basement to above the midpoint of the spinous layer, it is severe dysplasia. And if there is top to bottom changes, the report will be given as carcinoma in situ. Carcinoma in situ. Regarding the malignant potential of leukoplakia, there are many important factors that come to play to decide the malignant potential of leukoplakia. First is the site. So regarding the site, leukoplakia of the floor of the mouth, which is called as sublingual keratosis, and the lateral border and the ventral surface of the tongue and floor of the mouth is said to be the site prone for early malignant transformation and invasive squamous cell carcinoma. So in short term, these two sites are having highest malignant transformation potential. Second, regarding the type of leukoplakia, it is the erythroleukoplakia or spectral leukoplakia, which is having 18 to 47% of malignant transformation, whereas the homogeneous leukoplakia is said to have 1 to 7% of malignant transformation. And the third factor is the coexisting infection of candida. Candida in such situation is considered as a co-carcinogen. Whichever leukoplakia which has invasion of candida deep into the epithelial layer is prone to have more dysplastic changes. The third is the degree of epithelial dysplasia present on the biopsy and persistence of lesion for a long time. If there is a persisting white lesion for a long time, it is having more malignant potential. Occurrence in non-smokers and occurrence in females generally said to have a bad prognosis, more malignant transformation. So here I have shown you another case of classical verrucous leukoplakia. Majority of the time, if we take biopsy, it will be reported as verrucous carcinoma. Coming to regarding the staging that is used in relation to leukoplakia is first is the L that denotes the size of the leukoplakia. L0, there is no evidence of lesion. L1, less than 2 centimeter. L2, 2 to 4 centimeter. L3, above 4 centimeter. Lx, the size is not specified. The second criteria is the site. S1 is any site excluding floor of the mouth and the tongue. S2 is the most dangerous site, that is the floor of the mouth and the tongue. Third is SX is a site not specified. Regarding the clinical type, C1 is homogeneous type of leukoplakia, C2 is non-homogeneous type of leukoplakia, and CX, the clinical type is not specified. Regarding the histopathological features, P1, no dysplasia, P2, mild, P3, moderate, P4, severe, and PX, not specified. And this is the staging that can be used for describing leukoplakia, stage 1, 2, and 3, and 4. Regarding the treatment modalities available for leukoplakia, we can divide it into medical and surgical. Under medical treatment, we can try carotenoid, beta carotene, 20 to 90 milligram per day for 3 months, lycopene, 4 to 8 milligram per day for 3 months, vitamins, which can act as an antioxidant, including vitamin A, E, C, topical application of the cytotoxic drug called as bleomycin, 0.5 to 1% for 12 to 15 days. And this novel treatment also is getting more popular in treating leukoplakia, that is a photodynamic therapy, light activated chemicals or drugs used to treat leukoplakia. Regarding the surgical treatment, surgical excision with or without graft, and cryosurgery and laser ablations are also widely tried as a treatment tool for leukoplakia. So leukoplakia without exhibiting dysplasia, we can wait and watch periodically for the 6 months. Okay, and if there is if the habit is not discontinued, or if there is a change in the clinical appearance, we need additional biopsy to check the progression of the lesion. So here I show a case of homogeneous leukoplakia on the left buccal mucosa towards the angle of the mouth that was treated by a carbon dioxide laser. So it's the laser ablation. So once the lesion is treated with the laser, it appears as a wound, and it will heal as any other normal ulcer. So this is about the different treatment options for leukoplakia. Now coming to the erythroplakia, similar to leukoplakia, this is defined as a persistent velvety red patch that cannot be clinically or pathologically diagnosed as any other condition, like inflammatory erythema or those produced by the blood vessel abnormality. Here, the lesion will have a distinct demarcation from the adjacent normal tissue. So, etiology is generally idiopathic, but tobacco is considered as a factor, etiological factor. So why a red lesion appears red is because of the absence of surface keratin, and in the connective tissue papilla beneath the epithelium, there are engorged blood vessels projecting very close to the surface of the epithelium. So that gives a red color. So regarding the clinical features, like leukoplakia, this is also asymptomatic. Age predilection is towards sixth and seventh decade of life, and both male and female have equal predilection. And regarding the site predilection, floor of the mouth, ventral surface, soft palate, and fauces are the common site of occurrence. The clinical types include homogeneous, erythroplakia interspersed with patches of leukoplakia, that is the erythroleukoplakia, and speckled leukoplakia, small leukoplakic specks scattered over a large area of erythroplakia. These are the clinical types. So the importance of the lesion is majority of the time, 90% of erythroplakia is having malignant transformation. So early diagnosis and immediate treatment is the rule for erythroplakia. So 51% of clinically diagnosed erythroplakia on histopathology turned out to be grade 1 squamous cell carcinoma. 40% were carcinoma in situ or severe epithelial dysplasia, and 9% of the biopsied erythroplakia were having mild to moderate epithelial dysplasia. This is the reason we need to immediately attend a red lesion over a white lesion. So the clinical diagnosis is based upon the appearance of the red patch, and if any trauma from the tooth or restoration is considered, remove and watch the progression of the lesion. If there is no evidence of regression or healing in 2 to 3 weeks, biopsy is mandatory. Okay, and probable differential diagnosis, before you make a diagnosis of erythroplakia, we need to exclude the common inflammatory condition and vascular lesions like erythematous candidiasis, danger stomatitis, mucositis, tuberculosis, and vascular lesion. So regarding the treatment, if the biopsy shows dysplasia, we need to stop the tobacco habit, topical application of topical and systemic retinoids, and vitamin E and C, topical application of cytotoxic drugs like bleomycin, photodynamic therapy, and surgical excision. These are the possible treatment for erythroplakia. So just for the sake of completion, here I show before making a diagnosis of erythroplakia, the common condition that should be differentiated from erythroplakia are, here is a patient who is having diffuse erythematous areas in the palate, labial mucosa, and buccal mucosa, and the skin also showing erythematous rashes. This condition is in response to a systemically administered drug, and the changes in the mouth are called as allergic stomatitis. Here you see a diamond-shaped area in the dorsum of the tongue, in the middle of the posterior dorsum of the anterior two-third of the tongue. It is called as the median rhomboid glossitis. It appears as a red patch. Okay. And here are cases where you see a diffuse area of redness under the denture-bearing area, either involving the entire denture-bearing area or a majority of the denture-bearing area. It's called as the denture stomatitis. It should be differentiated from erythroplakia. So with this, I have come to the end of the first session regarding potentially malignant disorder. I hope you all enjoyed this video. And if you have any comments, please comment in the comment box. Thank you for watching my video. Thank you, one and all.